This talk is about the visual system and visual field defects. The talk will be conducted using conversational and question and answer formats. These are the class objectives. You do not need to read them. We will use them to chart our talk. The first question is, the pigmented epithelium is closer to the tip of the cones and rods than the ganglion cells. A true, B false. This is a representation of a dissected eye. Now I have placed a little rectangle in the retina, which I have now enlarged. Here I am indicating to the ganglion cell layer, here to the pigmented epithelium. The tip of the rods and cones are closer to the pigmented epithelium. So the answer to this question is true. Next question. The term used to refer to the glia retinal cells is dash cells. A. Muller, B. Horizontal, C. Amacrine, D. Bipolar. In this frame, we will represent the different layers of the retina. Neither the sclera or the choroid are considered retinal layers. The first layer of the retina is the pigmented epithelium. I have now introduced a cone connecting to a bipolar cell and a ganglion cell. As you can see, there is a one-to-one relation between cone, horizontal cell, and ganglion cell. I have now introduced two rods, conveying information to one bipolar cell, which then connects with a ganglion cell. Ganglion cells come in two types, P and M. The P stands for parvocellular or little cells, and the M for magnocellular or big cells. These cells are mixed in the retina. P ganglion cells exhibit color opponent responses and give sustained responses to stimuli in the receptor field. M ganglion cells do not exhibit color response, and they fire action potential when a stimulus is introduced, but quickly fade if the stimulus does not change. Rods do not have one-to-one relation with ganglion cell, as you can see in this frame. The amacrine cell make contact at the ganglion and bipolar cell level. The horizontal cell makes contact at the level of the bipolar and receptive sensory cell. I have now reintroduced the photograph of the retinal layers I initially showed you. You can see the sclera and the choroid. As we just mentioned, the first layer of the retina is the pigmented epithelium. This epithelium is in close contact with the choroid. Just above, we have the cones and the rod tips. This layer is called the receptor layer. Just above, we have the outer nuclear layer. Above, the outer plexiform layer. Then the inner nuclear layer. Then the inner plexiform layer. And finally, the ganglion cell layer. And not to be forgotten, the glia cells of the retina, the glia Muller cells. So the answer to this question is A. Please take a look at this frame and choose which number corresponds to the disc. The components of the normal retina are the disc, here indicated, has a sharp temporal side and a less sharp nasal side. It is pink. The overall contours should be cleared. The cup, that is the lighter part of the disc, should occupy less than 50% of the disc. Venous pulsation should be present. To see venous pulsation, it is at times convenient to look at veins in the periphery and trace it back to the disc. The veins look thicker than the arteries. Spontaneous retinal venous pulsations are caused by the fluctuating intravascular pressure gradient between the intraocular retinal veins and the retrolaminar portion of the central retinal vein. An increase in the pressure of the retrolaminar portion of the central retinal vein, which occurs with increased intracranial pressure, makes spontaneous venous pulsation disappear. An increase in the pressure of the intraocular retinal veins may bring about spontaneous retinal venous pulsations. This may be brought about by applying gentle pressure to the eyeball during fundoscopic examination. You can see that the macula is a red area, temporal to the disc. The macula is considered the zero meridian, thus in reality we should say that the disc is nasal to the macula. The macula fades into the retina. The fovea fades into the macula. The retina is pink, darker than the disc and lighter than the macula. It is important to say, before leaving the subject of the normal fundus, that in most instances the relation of shades of color is more important to detect retinal pathology than the color themselves. So the answer to this question is 3C. Next question. The fovea is a raised structure at the back of the retina. A true, B false. This is a right fundus. In it you can see the macula, the fovea. This is a microphotograph of the macula and fovea. You can see the sclera, the choroid, the first retinal layer, the pigmented epithelium. There are cones and rods bodies just above it. And here you can see the ganglion cells. Notice the thickness here and compare it to the thickness here. Again, notice the thickness here and compare it to the thickness here. This difference in width of the ganglionic layer helps define the macula. The macula is the area between the arrows, where the ganglion layer is thinner than in the rest of the central retina. The fovea is the area with no ganglion cells. The area of the macula around the fovea is called the parafovea. So the answer to this question is B. Next question. Cones are the main receptor elements in the fovea. A true, B false. In this figure you can see various elements that I will explain in the next few minutes. This structure indicated here represents a horizontal cut of the left eyeball. This is the nasal side. This is the temporal side. The element indicated by the arrow stands for cones per square millimeter. The y-axis in the chart indicates the number of visual elements per square millimeter. The x-axis expresses the perimeter angle, the fovea corresponding to 0 degree. 60 degree in the temporal retina corresponds to the edge of the temporal retina. 100 degree in the nasal retina corresponds to the nasal edge of the retina. The arrow in this frame points to the fovea. Where cones are greatly represented, their presence drops sharply as the distance from the fovea increases. But still, a significant number of them are present in the area close to the fovea and the parafovea. The blind spot obviously does not have any visual elements. So the answer to this question is true. Next question. Rods are more numerous in the central retina than in the peripheral retina. A true, B false. This is the figure I just showed you regarding cones. The new element I added represents rods per square millimeters. As you can see, the distribution of the rods is quite different from the distribution of the cones. The maximal concentration of rods is around the fovea in the central retina, decreasing in the periphery. No rods are present in the fovea, nor are they present in the optic disc. So the answer to this question is true. Next question. The fovea is basically devoid of all retinal cells except for cones. A true, B false. This is a cartoonish representation of the fovea and the surrounding region, to which I have included the macular glia cell, so you do not forget them. The fovea is where the cones are and ganglion cells are not, and the parafovea where cones, rods, ganglion cells are present. The neat separation I have represented in this drawing between the location of cones and rods is, as you know, not as cut and dry as represented here. Be it as it may, light comes through the pupil, hits the retina, and light rays go through the retinal layers, reaching the pigmented epithelium and reflecting, giving the retina the reddish appearance it normally has. So the answer to this question is true. Next question. During a routine first visit, you see findings below. You should send the patient for immediate admission and eye doctor consult. A true, B false. This is a histologic microphotograph. In it, you can see the disc, the axons of the ganglion cells in the retina, which are usually not myelinated, whereas axons of the ganglion cells in the optic nerve are myelinated. The boundary zone between myelinated and unmyelinated axon is the cribriform plate. Yet at times, myelin extends beyond the lamina cribriform and spills into the retina, taking the form you see in this photograph. Whereas in other cases, patches of myelin not in continuity with the disc are present, and they seem to have the same significance. Myelin in the retinal ganglion axons is a benign condition, but at times it is associated with visual disturbances. So the answer to this question is false. Next question. Select which fondi corresponds to retinal vein occlusion. This question presents three fondi. Number 1. Central retinal artery occlusion. This disc shows the typical finding of central retinal artery occlusion. Patients with this condition present with acute painless monocular vision loss. Fundoscopic exam reveal a cloudy fundus with attenuated vessels and a cherry red spot. This condition results from embolism of the central retinal artery. The embolism often arises from arteriosclerotic plaques. In this arteriogram, you can see the right internal carotid artery, external carotid artery, and internal carotid artery. The defect in the internal carotid artery indicate an arteriosclerotic plaque. In addition to sclerotic plaques in the carotid artery, the source of embolism can also be cardiac vegetations. The presence of an atrial septal defect increases the probability of a central retinal artery occlusion. At this point, I'd like to tell you a few words about cherry red spot. There are many conditions associated with cherry red spot, but three stands out in the literature. The one we just mentioned, in central retinal artery occlusion, a cherry red spot is due to opacification of the nerve fiber layer as they become edematous from ischemia. The fovea is cherry red because it has no overlying nerve fibers. The second one is due to accumulation of different lipids and mucopolysaccharides in the ganglion cells. Examples of this group are Tay-Sachs disease and GM1 gangliosidosis. In GM1 gangliosidosis, the cherry red spot is due to accumulation of GM1 ganglioside inside the ganglion cells. The fovea is cherry red because it has no overlying ganglion cells. Several substances have been associated with cherry red spot. Among them is carbon monoxide poisoning due to excessive exposure of this gas. The second fundus corresponds to retinitis pigmentosa. This is an hereditary biochemical dysfunction, specifically and initially affecting the rods. Rod dysfunction leads to retinal pigment epithelium damage and secondary cone damage. Clinical manifestation consists of nyctalopia or loss of night vision, gradual narrowing of the visual fields, of which this frame shows you an example, loss of accurate color discrimination, and photopsia. Photopsias may take the form of localized dots or shapes, flashes, white electrical noise as we see in a TV with no antenna, or background glow. Retinitis pigmentosa can occur as a non-syndromic condition or as a syndromic condition. One of the most common syndromic conditions associated with retinitis pigmentosa is Usher syndrome. In this case, retinitis pigmentosa is associated with neurosensory hearing loss. The distinction between retinitis pigmentosa that we have been discussing here and pigmentary retinopathy is often difficult to remember because of the similarities between the terms. Pigmentary retinopathy is a generic term where the fundus abnormality is due to migration of retinal pigment epithelium cells or macrophage into the retina. It is the final common outcome of many retinal and choroidal retinal disorders. It is a common manifestation of numerous metabolic and neurodegenerative disorders. This is the typical fundoscopic appearance of pigmentary retinopathy. The maximal pathology is usually in the posterior region of the fundus, close to the macula, most of the time. The pattern of pigment deposition has been described as salt and pepper. The third fundus corresponds to retinal vein occlusion. In this case, if the macula is affected, patients complain of blurry vision. More peripheral lesions produce visual field defects, and very peripheral lesions can be asymptomatic. Retinal vein occlusion occurs as the result of central artery narrowing by arteriosclerotic plaques, as shown here. The dilatation of the artery to provide flow to the retina compresses the vein, causing retrograde bleeding. As expected, this situation is normally linked to patients with high blood pressure and diabetes. So the answer to this question is C. Next question. Age-related macular degeneration. Match the appropriate retina. Hypertensive retinopathy occurs with rather typical fundoscopic findings. Probably one of the earliest findings is arterial narrowing, which at times takes the form of copper wiring when the artery appears orange or yellow instead of red, or silver wiring when they look white. In addition to arterial narrowing, we find arteriovenous nicking. This is a photograph of a normal artery vein crossing. Arteries are thinner and cross on top of the thicker veins. This is an illustration of the crossing. This is a photograph of arteriovenous nicking. The vein appears compressed at the crossing with the artery, but also thicker shortly after. This is an illustration of this phenomenon. Notice that the vein is thicker just above the artery and below the artery. In addition, patients with hypertensive retinopathy may show flame-shaped retinal hemorrhages and cotton wool exudate. At times, the exudate takes the form of a star around the macula, as you can see in this frame. In addition, occasionally we find papilledema. This constitutes an emergency that warrants immediate ophthalmological evaluation. Some patients with hypertensive retinopathy also have isolated or crops of microaneurysms in the retina, as you can see here. Another cause of retinopathy is diabetes, which has a non-proliferative and a proliferative phase. The non-proliferative phase presents with cotton wool spot, severe macular edema, and blood hemorrhage. The proliferative phase is characterized by new vessel formation in the disc and far from the disc. Also, preretinal hemorrhage are often present. Age-related macular degeneration is probably the most frequent eye condition encountered by general practitioners. This condition is familiar. Family history is the main risk factor for developing AMD. But good living, not smoking, taking vitamins, antioxidants, and having brown eyes seems to help. Age-related macular degeneration has two phases, as we previously mentioned. But in addition, there is a burnout phase, when the scar tissue replaces evolution. The first phase is called the dry phase. In this phase, drusen, yellow deposit of fatty protein, accumulates under the retina, as indicated here. Vascular endothelial growth factor appears locally, producing choroidal neovascularization. At this stage, the macula shows white patches due to drusen, as you can see here. The second phase is called the late or wet phase. As you recall, this is a representation of the dry phase. Early in the wet phase, vessel forming spreads and more vascular endothelial growth factor is present. Choroidal neovascularization increases and more exudate is present in the choroid. Then neovascularization appears in the spaces previously occupied by the drusen, and exudate permeates through the receptor layer of the retina going towards the ganglion layer. At this stage, fundoscopy shows exudate and often bleeding. This phase is referred, as we previously mentioned, as wet phase. The third phase, which is not an evolutionary phase, is scar formation. During the scar formation phase, months or years after the wet phase, scar tissue is formed, giving the fundus a paler and darker mixed appearance in the area corresponding to the macula, as shown here. The clinical evolution of age-related macular degeneration goes hand in hand with fundoscopic changes, and it goes as follows. As represented here, this is a picture of normal vision and a normal fundi. In the dry stage, the image in the center becomes blurry. In the wet phase, central vision interferes with facial recognition. And in the late wet phase and in the scar phase, a central scotoma is present, precluding any vision in the central point of fixation. This is a representation of the normal visual field of the right and left eye. Patients with age-related macular degeneration have central scotomas, as you can see in this frame. So the answer to this question is C. Next question. A patient is referred to you by an optometrist because of an enlarged blind spot. Which of the following fundoscopic findings are you likely to find in this patient? Please take a look at this fundi and choose the most appropriate answer. This question has three fundoscopic pictures. The first one corresponds to retinal detachment. Part of the retina appears as if covered by a blanket. Another clue is that vessels change trajectory. You can see an example here. The projected trajectory of this vessel, indicated by the arrow, is likely to follow the line just drawn, yet it goes down. So what causes retinal detachment? Retinal detachment is due to separation of the photoreceptor layer from the outermost pigmental epithelium layer, as I will show in the next frame. This is a photograph of an optic nerve and the retina showing an attached segment of the retina and a non-attached segment. The arrow points to the photoreceptor layer and the new arrow to the retinal pigmented epithelium layer in the attached segment, and now in the non-attached segment. This photograph makes it easy to see where the detachment occurs. Risk factors for retinal detachment are high myopia, head trauma, and posterior vitreous detachment. Clinical manifestation consists of monocular loss of vision like a curtain drawn down. Retinal detachment is a surgical emergency. I will talk about the second fundoscopic appearance by use the case of Foster-Kennedy syndrome to describe two important fundoscopic findings. You can see here a large mass in meningioma. Fundoscopy of the right side, the side of the mass, showed optic atrophy. The color of the optic disc is more pale than expected. Fundoscopy of the left eye showed raised and blurry disc margin consistent with papilledema. Notice that the margins of the disc are blurred and the edges are raised. Papilledema often produces an enlarged blind spot. The blind spot is a physiologic exotoma produced by the optic nerve. The blind spot is usually small and difficult to detect during regular visit to the optometrist to get new glasses. An enlarged blind spot is often present in patients with papilledema. The third fundoscopic picture has this dramatic appearance. Large segment of the retina is yellow or white. This fondi corresponds to this patient. The white area, the tumor, is visible following pupillary dilatation, as you can see in this frame. This is called leukocoria. This lesion occurred with a retinoblastoma in this case. But there are many conditions associated with leukocoria. Retinoblastoma is one of them. Another one is cataract. So the answer to this question is B. Next question. The optic nerve are myelinated by Schwann cells. A true, B false. The optic nerve is myelinated, as you can see in this photograph, by oligodendrocyte, the little cells that look like fried eggs. Embryologically, as you can see in this sketch of a 5-week conceptual age embryo, the diencephalon has two bulges. They are the optic vesicles. It is from these vesicles that the retina and the optic nerve derives. Here, you can see a different view of the optic nerve as well as the rest of the visual system. The chiasm, optic tract, which you can see now in this lateral view, the lateral geniculate, a thalamic nucleus can be seen here and here. Coming out from the lateral geniculate nucleus, you have the optic radiations. Fibers from the inferior half of the retina after laying in the lateral geniculate nucleus form the Meyer's loop, which goes forward in the temporal lobe before going backward to the occipital lobe. Those from the upper half of the retina after laying in the lateral geniculate nucleus go rather straight back to the parietal lobe to the occipital lobe. At the occipital lobe, the optic radiation make contact with visual cortical neurons. This is a histological specimen of a parasitical cut from Yakovlev-Hallen collection. In it, you can see the parieto-occipital sulcus, the calcarine sulcus, the cuneus gyrus, lingular gyrus, as well as the cingulate sulcus. I have now introduced a blue rectangle at the cingulate sulcus, a red rectangle at the calcarine sulcus. These rectangles are now enlarged to better appreciate the cortical architecture. Notice in the calcarine cortex the thick dark band of myelinated fibers. This is called the band of Gennari and consists of a very prominent outer band of Ballinger. So the answer to this question is false. Next question. The optic nerve is surrounded by A. dura, B. arachnoid, C. pia, D. all of the above. You have seen this photograph before. In it you can see the optic disc, unmyelinated ganglion axons in the retina, and myelinated ganglion axons in the nerve. A cut at the indicated level will show a multicircular structure made of dura, arachnoid, pia, and nerve. You will also find inside the nerve the central vein and central artery. So the answer to this question is D, all of the above. Next question. The von Willebrand knee corresponds to fibers from one optic nerve going to the other optic nerve. A true, B false. This is the optic chiasm. This is an schematic representation of the visual pathway. The arrow is pointing to the chiasm, which I have now enlarged. We all know that nasal fibers from each eye traveling in the optic nerve cross to the contralateral optic tract as represented in this drawing. But to understand the optic chiasm, we must at least divide the incoming optic fibers in quadrants, as I have done here, and consider the fate of each quadrant separately. To do so, in this drawing, I will color each quadrant differently. In this frame, I have colored the inferior nasal fiber magenta, violet for the inferior temporal fibers, aqua for the superior nasal fibers, and yellow for the superior temporal fibers. The inferior nasal fibers, as shown here, after crossing to the other side, go forward into the contralateral optic nerve. In the contralateral optic nerve, these fibers travel towards the opposite eye for a short distance before turning back and heading to the optic tract. The inferior nasal fiber incursion into the contralateral optic nerve has been called the von Willebrand knee. Fibers from the upper nasal quadrant also cross, but they do not go into the optic nerve. Fibers from the temporal retina just go back towards the optic tract. So the answer to this question is true. Next question. The eye on the right side sends information to the right lateral geniculate layers A, 2, 3, and 5, B, 1, 4, and 6. This is a view of the midbrain, the optic chiasm, and the optic tracts. The optic tracts extend from the chiasm to the lateral geniculate nucleus. And here you can see the optic tract following some dissection. This is a high midbrain specimen. You can see the optic tracts arriving at the lateral geniculate and fibers from the lateral geniculate forming the optic radiations. You can also see the medial geniculate nuclei in this frame. I have now encircled the lateral geniculate nuclei. The strip structure I have just indicated are these nucleus, and that's how we recognize them. In this frame, you can see the geniculate in isolation. The geniculate has 6 layers of gray matter made of primary neuron bodies with intervening white strata, mainly made of axons and dendrites. The second, third, and fifth layer receive fibers from the ipsilateral eye. Layers 1, 4, and 5 receive fibers from the contralateral eye. The lateral geniculate also receive fibers from other areas. These fibers control information the lateral geniculate passes on to the occipital cortex. These fibers originate at the primary visual cortex in mesencephalic reticular area. Most of the lateral geniculate neurons serve the macula and are located in the middle of the structure. Unlike in the retina, where magnocellular and parvocellular cells are segregated, in the geniculate they are clearly separated. Magnocellular cells are found confined to layer 1 and 2. They, as the magnocellular ganglion cells in the retina, contribute to fast and transient processing such as it is required for visual motion perception and eye movements. Parvocellular cells occupy the last 4 layers and contribute more to objects and face recognition. So the answer to this question is A. Next question. All optic radiations curse through the temporal lobe. A true, B false. This is a representation of the lateral view of the brain and the eyeball. The lower retina is colored magenta, the upper aqua. In this area, the structure I just added represents the lateral geniculate nucleus. Now I am pointing to and drawing the upper bank of the calcarine cortex, and now the lower bank of the calcarine cortex. Fibers from the inferior retina travel to the lateral geniculate nucleus and from there to the lower bank of the calcarine cortex. The trip from the lateral geniculate nucleus is not straight. The fibers from the lower retina fan forward, getting into the anterior temporal lobe, as indicated here, forming the Meyer's loop, before ending up at the lower bank of the calcarine cortex. The fibers from the upper retina, after reaching the lateral geniculate, go to the upper bank of the calcarine cortex by way of the parietal lobe. So the answer to this question is false. Next question. According to the dorsal ventral visual pathway theory, the cerebral area involved with where and how is in the parietal lobe. A true, B false. In this frame, you can see the visual pathway, starting at the retina and ending at the primary visual cortex in the occipital lobe. And I have represented the primary sensory cortex here. The structure I have just added represents the unimodal association area, and this new structure, the multimodal association area. As you can see represented in this frame, the right eye is blocked. I have now introduced a half-full glass sitting on a table in the view of the left eye. This figure will be perceived at the primary visual cortex upside down and the right side of the figure in the left hemisphere and the left side of the figure in the right hemisphere. At the unimodal association area, the figure would be inverted to upright and the side corrected, but still the person would not know where it is, what it is for, nor what to do with it. Then the image goes to the multimodal association area, where the information would be analyzed on the basis of past visual memories and memories from other sensory systems. It is here, at the level of the multimodal association area, that it is decided where and what the object is for. So, what is the dorsal ventral visual pathway theory? This is a photograph of a brain from the back. The dorsal ventral visual pathway theory states that different information is processed at different areas of the unimodal and multimodal visual regions. I have represented this by using different colors for the two pathways. The M pathway or dorsal pathway is made of chain of neurons starting with the M ganglion cells in the retina that go to the parietal lobe from the primary visual cortex. This pathway deals with where the object is located and how the object is used, whereas the ventral or P pathway, corresponding to the chain of neurons starting with the parvocellular ganglion cells in the retina, take the information a different route. It goes to the temporal lobe towards the fusiform gyrus and deals with what the object is, hence object identification. So the answer to this question is A. Please take a look at this visual field and match with the corresponding lesion site. I like to start this section about visual fields reviewing some basic concepts. Visual fields must be tested one eye at a time because, as you can see in this representation, if not done so, visual defects will be missed. Binocular vision testing will miss monocular fields, defects, and even bilateral defects will not be apparent when using binocular vision testing if different visual fields defects are present in each eye. Take a few seconds to look at this representation. The first picture represents an scotoma as viewed by the left eye. The middle picture, an scotoma as viewed by the right eye. And the third picture, no scotoma when viewed with both eyes open. Early on, visual fields were performed using tangential screen, as you can see here, complemented by the use of Amsler grid to assess central vision loss. Central defects produce significant distortion on the grid close to the fixation point, as you can see in this frame. Later, the Goldman perimeter was used. This was less labor-intensive but still time-consuming. Currently, visual field testing is done using home-free visual field testing equipment. This is a computerized system that does not require specialized personnel to be conducted, and it is done relatively fast. But the results are difficult to interpret by general practitioners. Hence, in this talk, we will use tangential representation to talk about visual fields. This frame shows tangential recorded visual fields. OS means left eye, OD means right eye, each eye being represented separately and from the perspective of the patient being U. The area in the cream corresponds to the extent of regular vision. The black dot in each field corresponds to the blind spot. The place where the lines converge is the center fixation point. I will use this figure representing the visual pathway and in it indicate the site of lesion producing visual field defects. This other figure will also be used when lateral view is required to understand the location of the lesion. It is important to stress the obvious. It is not the nature of the condition but the anatomical location of the lesion that determines the visual field defect. So, visual field defect do not correspond to etiology but to location. Yet, locations help determine etiology. In the question I just presented to you, there are 4 choices. I will introduce each choice, showing you a normal visual field followed by the visual field that corresponds to the deficit being considered. Choice 1. So, this is normal. This is abnormal. This visual field corresponds to a left complete monocular blindness. This field abnormality is produced by an anterior left optic nerve lesion. Monocular blindness can be total, as in this example, or partial if only some fascicles of the optic nerve are involved. This is an MRI of a patient with an optic nerve glioma, as you can see in this transverse and sagittal view. The patient had neurofibromatosis. She presented with left ptosis due to a plexiform neurofibroma. Choice 2. This is normal. This is abnormal. This visual field corresponds to right monocular blindness and loss of vision in the left eye upper quadrant. This visual field defect is seen with injury to the optic nerve close to the chiasm due to involvement of the von Willebrand knee. This visual field defect is often seen in patients with anterior middle fossa lesion involving the right optic nerve near the chiasm. Choice number 3. This is a normal visual field, this is an abnormal visual field. This field defect is called bitemporal hemianopsia, corresponding to a lesion in the chiasm. This is a CT scan of a patient I saw many years ago. She had a midline lesion in the chiasmatic area, as you can see. As confirmed in this coronal view, the tumor was a craniopharyngioma. Craniopharyngiomas are resectable lesions that originate at Ranke's pouch. In this case, the tumor was removed and she did very well. Choice 4. This is a representation of a normal visual field. This visual field corresponds to an incongruous left ipsilateral hemianopsia. This visual field defect is produced by right optic tract lesion. Left hemianopsia can occur with lesions in the optic tract or optic radiations. Incongruity is characteristic of optic tract lesions. This MRI shows the typical location producing this type of visual field defects. This patient had multiple sclerosis. So the answer to this question is B. Next question. Please take a look at these visual fields and choose the correct location. In this question, you have 4 choices indicating 4 different locations. Choice number 1. This is a normal visual field. This visual field corresponds to a homonymous left upper quadrant topsia. The term pie in the sky is often used to describe this visual field. This visual field defect is produced by a lesion in the temporal radiations, often involving Meyer's loop, as indicated here and here. This type of visual field defect can occur as a complication of anterior temporal lobectomy for seizures. If the surgeon goes too far back from the tip of the temporal lobe, the Meyer loop may be cut. This type of visual field defect can also occur with more posterior temporal lobe lesions involving the temporal radiations, such as with strokes involving the middle cerebral artery. Or it can also occur with tumors in the mid-temporal region as shown here. In this case, the lesion was an oligodendroglioma. Choice number 2. This is a normal visual field. This visual field corresponds to a left inferior ipsilateral quadrantopsia. This lesion is usually referred to as a pie in the floor. This visual field defect is seen with parietal lesions as depicted here and here. Middle cerebral artery strokes can also produce them, as well as the stroke lesion, as you can see in this MRI involving the right parietal region. This is a drawing primarily depicting the fibers traveling in the internal capsule, showing the optic radiation in the posterior area of the internal capsule. This drawing from a very old anatomy book depicts the trajectory of the parietal optic radiations in the internal capsule. Choice number 3. This is a normal visual field. This visual field defect corresponds to congruous right homonymous hemianopsia. This visual field defect occurs with left lesion involving the parietal and temporal lobe posteriorly, as the fibers from the parietal and temporal radiations come together. You can see this MRI the typical location of such a lesion. Fourth choice. This represents a normal visual field. This is a representation of a right homonymous hemianopsia with macula sparing. This type of visual field defect occurs with lesion involving the fibers as they arrive to the visual cortex or the visual cortex itself, as represented here and here. This type of MRI lesion is the one that tends to produce this type of visual field defect, that is right homonymous hemianopsia with macular sparing. The MRI finding corresponds to a left posterior cerebral infarct. The reason for macular sparing relates to arterial irrigation. The area that corresponds to the macula in the cortex has bilateral irrigation from the posterior and middle cerebral arteries. Hence, a stroke involving one of these arteries, usually the posterior cerebral artery, spares macular vision. This usually does not occur in cases of tumors in the occipital pole. So the answer to this question is D. Next question. Please take a look at these visual fields and match it with a corresponding lesion. As in previous question, you have 4 choices. I will talk to you about anatomy of the retinal fibers as a prelude to discussing the first 2 choices in this question. This is a representation of the trajectory of ganglion cell axons going to the disc. I have now highlighted the papillomacular fibers. Papilla is another name for the disc. The papillomacular fibers are very compact bundle of axons with high metabolic requirement. Notice that they enter the disc by its temporal side. I have now introduced the inferior arcuate fibers and the superior arcuate fibers. Notice that these fibers do not cross the equator. The distribution of these fibers is important to understand visual field arising from disc pathology. I will now introduce the first visual field following the same approach as I did in previous questions. Choice 1. This is a normal representation of visual fields. This visual field defect corresponds to involvement of the papillomacular fibers. This visual field abnormality is called centrocecal scotoma. This is called so because it is an scotoma that goes from the central fixation point to the blind spot. As you can see, better appreciated in this enlargement. Centrocecal scotomas are associated with optic neuritis, toxic neuropathy due to drug intoxication, nutritional neuropathies such as B12 deficiency, and hereditary optic neuropathy of Leber. Choice number 2. This is a representation of a normal visual field. These are arcuate visual field defects. They are usually seen in a condition called sarca. This picture tells why it is so. The term sarca was used by medieval Arabian authors to refer to glaucoma. Visual field tests in glaucoma produce many types of scotoma, but 2 are very characteristic. The classic arcuate defect, which is a coma shape arising from the blind spot without peripheral extension, or the less classic field defect with peripheral extension. Both of these defects respect the nasal visual field equator as indicated here and here. The reason for this is easily understood by remembering the arrangement of the ganglion axons in the retina, and that the most vulnerable retinal fibers to intraocular increased pressure, as occurring in patients with glaucoma, are those in the inferior region of the disc. Thus, damage to the inferior arcuate fibers produce a coma-shaped scotoma respecting the horizontal raphe. The scotoma, at times extending to the periphery as indicated here, also respect the horizontal raphe, as you can see in this frame. So the answer to this question is B. Which of the following findings indicate involvement of the ventral visual stream? A. Neglect. B. Simultapnosia. C. Optic ataxia. B. Prosopagnosia. I will mention 6 conditions involving visual field higher cortical dysfunction. It is important to stress that all primary functions related to the activity being considered must be normal in order to diagnose a higher cortical functional defect. Number 1. Dorsal pathway pathology produces neglect. The patient with neglect is unable to report, respond, or orient to external visual stimulation or mental images. If asked to bisect the line, the patient does so on one side because in the patient's mind, the chosen location is the midline of the line. If asked to draw a picture, one side of the picture will be missing. Neglect occurs with contralateral inferior parietal lobe lesions. Visual neglect is more common with right hemispheric lesions. Second condition, simultagnosia. This form of dorsal pathway abnormality consists of inability to perceive the field of vision as a whole. A person is able to identify parts of an object, but unable to identify the whole object. Simultagnosia occurs with bilateral parieto-occipital lobe lesions. The third condition, optical ataxia. This dorsal pathway abnormality refers to impaired visual control of the direction of arm reaching for an object. It occurs with bilateral parietal occipital lobe lesions. The fourth condition I will mention involves the ventral pathway. This condition is called akinetopsia. It is the inability to recognize motion. It is due to bilateral occipitotemporal lobe lesions. The fifth condition I will mention also involves the ventral pathway. It is called prosopagnosia. It consists of inability to recognize familiar faces, as not being able to recognize George Washington from a painting, and at times not being able to recognize themselves by looking at a mirror. This condition is due to bilateral occipitotemporal lobe lesion, often involving the mid-fusiform gyrus. The sixth and last condition I will mention is visual agnosia. It's also due to ventral pathway abnormality. Patients are unable to identify objects. This abnormality occurs with bilateral occipital temporal lobe lesions, especially those involving the inferior longitudinal fascicle. So the answer to this question is D. Thank you very much for your attention.